BC here for BC Nephro. Thanks for watching. I'm Dr. Brian Cronin, board certified nephrologist and clinical specialist in hypertension. Today's topic, treatment of hyperkalemia. For an overview of hyperkalemia, including causes and pathophysiologic mechanisms, check out my other video and article. I'll link both in the description below. But now let's get into it. Treatment of hyperkalemia, there's 4 general approaches that we'll go through. First, decrease potassium intake. Second, increase potassium excretion from the body. Third, drive potassium from the extracellular to the intracellular space. And fourth, stabilize cardiac membranes. The main treatments are going to depend on, first, the acuity, and second of all, the severity of the hyperkalemia. Hyperkalemia can either be acute or chronic. Acute hyperkalemia is most likely due to shifts of potassium from the intracellular to the extracellular space. Most of the potassium normally is in the intracellular space. There are some pathologic conditions where potassium can leak out, including tissue ischemia, rhabdomyolysis, severe hyperglycemia, or insulin deficiency, such as in ketoacidosis. Acute hyperkalemia is of a concern for a couple reasons. One, it is more likely to be severe, and second, there is a more sudden drastic change in potassium, so there's more likely to be complications as the body has not had an opportunity to adapt. Now, chronic hyperkalemia is most likely due to a decrease in potassium excretion from the body, which is due to some problem with the aldosterone-sensitive distal nephron, either problem with aldosterone or problem with the tubules or sodium delivery there. Now, severity of hyperkalemia is typically divided into mild, moderate, and severe. Mild hyperkalemia is from the upper range of normal to 5.5. Moderate is in between 5.5 and 6.5, and severe is greater than 6.5. I typically divide moderate into 2 subgroups in my treatment. Mild to moderate, I would consider 5.5 to 6, and moderate to severe, I would consider 6 to 6.5. All right, so let's get into the specific treatments. First, diet. Restrict potassium intake. Diet is not the sole cause of hyperkalemia, but it can aggravate hyperkalemia due to other causes such as decreased renal excretion. This is a little bit difficult or tricky because many high potassium foods are actually healthy foods that you in general would encourage people to eat. So the key here is to avoid foods or substances that have high or very high potassium content but may not offer nutritional value. So we're thinking here about stopping potassium supplements. Certain over-the-counter supplements, health supplements, contain high potassium, stopping those things, and avoiding the very highest potassium foods, especially if they have little nutritional value. This restriction or decreased intake would be the mainstay of treatment for mild hyperkalemia, but is applicable to all levels of severity, mild, moderate, and severe. Next, remove potassium from the body. So potassium can be removed from the body both by the kidney and from extrarenal sources. The first step in improving potassium removal by the kidneys would be to look for medications that impair renal potassium excretion. A full list will be in the article linked in the description below, but some of the common ones are renin-angiotensin system blockers such as ACE inhibitors and angiotensin receptor blockers, potassium-sparing diuretics, mineralocorticoid receptor antagonists such as spironolactone, NSAIDs, and trimethoprim, which is in the antibiotic spectrum. So in these cases, if the potassium is mild to moderate in between 5.5 and 6, I'm looking to either decrease the dose of one of these medications, or if the patient is on 2 of these medications, maybe stop one of the 2 medications that is less important for the medical care. If the potassium is above 6, I'm holding all these medications. If it's moderate or severe, I'm holding all these medications until we get things straightened out. Now, there are other ways to increase potassium excretion through the kidneys. These include most diuretics, thiazides, and loop diuretics. They include the mineralocorticoid agonist, fludrocortisone, and there can be a forced diuresis. So if there's a patient with either mild or mild to moderate hyperkalemia, especially if they're on one of these other medications that's important for their health, such as a renin-angiotensin system blocker in proteinuria chronic kidney disease or diabetic kidney disease, you may look to add one of these. Add a thiazide diuretic if there's hypertension that's not controlled to target. Add a loop diuretic if there is edema. If the patient doesn't have one of these conditions, doesn't have edema, and has a relatively low blood pressure, you can consider fludrocortisone. If we're talking about moderate to severe hyperkalemia and the patient has residual kidney function, residual urine output, I like to try a forced diuresis with a combination of saline and intravenous loop diuretics. If the patient's hypovolemic, I would initially try saline alone. If they're hypervolemic, initially try the loop diuretic alone, but often a combination of both at some point can help eliminate potassium from the body in these more severe levels of hyperkalemia. Now, for the extrarenal ways to remove potassium, this can be done by the GI tract. There are binders, traditionally K-oxalate, sodium polystyrene sulfate. More recently, 2 agents have been developed. One is called Potassium, which goes by the brand name Veltessa, and one is sodium zirconium, which goes by the name Lokelma. These cases I would use for mild to moderate hyperkalemia, potassium 5.5 to 6, only if it was necessary to allow continuation of another medication such as a renin-angiotensin system blocker. Otherwise, I would reserve these to moderate to severe hyperkalemia, potassium 6 to 6.5 or above 6.5. And the final way to remove potassium from the body is through extracorporeal mechanisms such as dialysis. So this is going to be necessary in a patient without residual kidney function, a dialysis patient, or acute oligonucleotide kidney failure. It is typically reserved for more severe hyperkalemia, that is potassium above 6.5, that is refractory to the initial treatment, especially if there's EKG changes. Okay, the third step has to do with driving potassium from the extracellular to the intracellular space. This is going to be the initial treatment for patients with acute hyperkalemia that is more severe, moderate to severe. This is not going to be effective for chronic hyperkalemia, but for the acute hyperkalemia, you can drive the potassium into the cells, get it to a safer level, where until the underlying pathophysiologic process can be addressed, or until you remove potassium from the body by another mechanism, allowing more time for the pathophysiologic process to be addressed. So the mainstay is actually a regimen of insulin and dextrose. It's the insulin that drives the potassium into the cells. The dextrose is given concomitantly to prevent hypoglycemia. The other thing is albuterol. An extended albuterol nebulizer can drive potassium into the cells. The third thing is bicarbonate. Now, bicarbonate is ineffective unless there is an acidosis. So in a severe case, acute case, if there is a concomitant metabolic acidosis, I would give intravenous bicarbonate. This is the one case where you might use something for chronic hyperkalemia. If someone has chronic kidney disease with a metabolic acidosis, adding sodium bicarbonate is likely helpful for them anyway and may help control the hyperkalemia. Now finally comes stabilization of the cardiac membrane. This is done by giving calcium, which stabilizes the membrane for 30 to 60 minutes to allow time for some of these other treatments to take effect. We typically give calcium gluconate. Calcium chloride is more potent, but it is sclerotic and irritating to the veins. Calcium gluconate is less so. One thing to be careful of, to be mindful of, is cases of digoxin digitalis toxicity. Now, digoxin works by poisoning the sodium-potassium ATPase. This allows an electrical chemical gradient to allow more calcium to go into the cells, and this typically helps cardiac contractility. However, if there is severe toxicity, one of the symptoms of severe digitoxicity, if the sodium-potassium ATPases are completely paralyzed, would be hyperkalemia because the potassium cannot get into the cells. In this case, the electrical chemical gradient is very high, and if you give intravenous calcium, that can rush into the cardiac cells and precipitate an arrhythmia. So be mindful of this in your patients on DIG to exclude digitoxicity prior to giving intravenous calcium. So that's it. Thanks for watching. If you found this useful, please share it with someone else who you think might learn from it, might be interested in this topic. And if you made it this far, you might as well hit like and subscribe, leave a comment. Things like this help the channel and help get this message spread to more people. And until next time.